about how the province is managing this shortage. We're joined by Dr. Freddy Kgongwana, who is the acting DDG of Hospital Services in the province. Dr. Kgongwana, good evening to you, and thank you so much for your time tonight. So when we talk about the province facing a capacity problem, how deep is that problem? How many beds do we not have?
We really never had a challenge with capacity. We had pressure on our high care and our ICU beds. Remember, the province has, outside COVID, has got about 18,000 beds, which have been there to engage around all the medical needs of the province. But when COVID hit, for example, after this second wave, we had a baseline of 2,000 beds, which were designated for COVID-19. And with the peak of the third wave, we were at 4,000 beds that were designated for COVID-19. So it was more of an issue of personnel. Because remember, the high care and critical care staff in the country and even in the province and internationally is a very scarce skill. So you're competing with the private sector, you're competing with other stakeholders on those scarce skills. But we never ran out of beds. We had pressure on our high care. And as you remember also COVID-19, the Delta variant hits your lungs very badly. So there had been more of a demand for high care and ICU beds. We had pressure on that, but we really never ran out of beds. It was been an issue of having to have the appropriate staff at the right place. Remember, we're more interested in the outcomes of the healthcare. We have had added about 999 beds over the 18,000 that we have. Those were designated for COVID-19, over and above the 18,000. That were specifically built in what we call our alternative building technology new facilities. Right.
But Dr. Kgongwana, sorry to come in there.
No problem.
If you've got beds, but you don't have the personnel that can actually treat patients who could well be using that beds, then you don't have those beds. It's as good as not having that capacity within the hospitals.
Yeah. Okay. Let me. There is why when you talk about beds, it's important to understand that we never had a shortage of beds, but we had a challenge in terms of functionalization, right? But we were capable and able to escalate because we approached it in what we call a risk-adjusted approach. That's why at the end of the second wave, we were at 2,000. And as the wave went up, we went to 3,000. And as it went up, we went to 4,000. And those were functional beds, those 4,000, within our facilities. And there was no stage, those functional beds, those 4,000 beds, which are functional, that had staff to manage, did not have those beds. But let me give you a scenario which is the reality in terms of COVID-19. COVID-19 changed the way we triage, right? And some of the key challenges that we experienced were where you would have individuals that will come in, you triage them, so you go left, you go right. But with COVID, you had to make sure that this individual doesn't have COVID. And it ended up having a lot of congestion in our accident emergency unit. And that is where a number of the complaints and concerns that came from our communities, the congestions in our A&E, because you needed to make sure that you do not mix people that are COVID positive with COVID-19. It's a new conundrum. Even if you look at the emergency services, right, the turnaround time was extended because after the ambulance has delivered the patient, they have to sanitize. So COVID-19 came with sort of a new conundrum where we have to make sure that we do not get you, when you come to our facilities, have COVID. And that introduced a whole lot of an extension into our triage system. So I think a lot of experiences that our communities had was this congestion in our accident emergency, because there's the first place where people arrive at any time. And we had to make sure that we do not create super spreader events, and that adds into your pressure.
So then why were patients at Helen Joseph Hospital in some instances turned away because there was no capacity? That hospital didn't have capacity to actually take them in.
assertion of turn away, we need to really clarify that. I would like to have details. What does that turn away mean? Right? What does it mean? I'm glad that you touched on Charlotte, right? That yes, Charlotte had a major impact to the stability of accessible beds. That is why we're glad when Charlotte started coming back into commission, and it is not fully commissioned because there's still issues with the City of Joburg to have compliance and issues like that. But I would like to have, what does it mean turn away? Let me share with you one of the systems that we have in the province. We have what we call ambulance diversions in the province. It's a system where we try to share the resources that are scarce in the province. So when Helen Joseph experiences pressure, there would be a diversion given so that ambulances, instead of taking those patients to Helen Joseph, they would take them to other facilities, Bara, for example. So it is a system that has been there in the department to try and manage the scarce resources that we have, particularly high care and critical care. But remember, we are not the Department of COVID-19, we are the Department of Health. So there's still care that still need to give into your maternity, your mental health, the trauma that exists in our country for whatever reason, and so on and so forth. So it is a fine critical balance, and we have to manage the clinical risk. We also have to make sure that the staff. Remember, even the staff gets affected. We have lost staff members, healthcare workers, out of COVID. So COVID doesn't play fair. It's a very difficult conundrum. And we had to do our best not to panic, but get focused. So within the 4,000 plus beds that we have designated for COVID, we never ran out of beds. However, remember, there will be pressure on a particular institution, and that is why we have a diversion system. We've got the system where we call medical management call. Every day there's a medical management call for the province to say, this hospital is under pressure, let's divert ambulance to another institution so that those guys can reorganize themselves and be able to make sure that the systems that are often disrupted by a lot of pressure and congestion are reasonably sorted out. It is a risk situation that we have to work with on a daily basis.
Dr. Kgongwana, you describe it as pressure on your facilities, but when we speak to different organizations, whether it's those that are representing doctors or even those that are representing nurses, we are told of situations where there is an expectation on, let's say, nurses in ICU to treat up to 8 times more in terms of the number of patients that they would ordinarily care for. And that calls into question the quality of care that people are actually receiving, even when they are admitted to hospital.
Let us be very honest as a people, as a country, that COVID-19 doesn't play fair. COVID-19 presented extreme pressures and unusual challenges that we've never faced as a healthcare system or even as a community. We have lockdowns. There have never been lockdowns before. We had healthcare workers dying in such huge numbers and even communities dying. So we cannot ignore the impact of COVID-19 on demand. You've seen even overseas. You remember in Spain, they had to use ice rings for mortuaries. So let us not neglect and ignore the reality of the pressures and the difficulties that COVID-19 presented as a conundrum in the healthcare system. But even
that being the case, Dr. Kgongwana.
Let me finish this point.
Yeah.
Let me finish this point before you come to the point. The issue is that, you see, it becomes like a royal cow. Like you said that people have been sent away, and that's a problem. But when we have everybody being given a chance to healthcare services, even when we had a congestion, it's also a challenge. So how do you advise us as a healthcare system to be able to make sure that within the resources and the limitations we have, provide our communities with appropriate care? You see that, yes, the activist units have to be active in terms of protecting the sectors like the medics, your clerks, your porters, your nurses. But at the end of the day, let us also not ignore the dedication that these cadres in our system have been able to contribute to us making sure that we come to a point where even the curve has been flattened. It is not easy, and it will never be. not very complex. It'll never be. But we just cannot relax and throw our toys out of the cot and pull our hair out. We have to be committed, focused, dedicated. It's hard. It's scary. But we have to do our best. It's not because we want to abuse each other as healthcare workers or abuse. There's very dedicated, there's 68,000 healthcare workers in Gauteng for a population of 15 million. We have to respect and appreciate and do our best to support one another to make sure that we reduce the impact of COVID-19 in our communities. And like I've said earlier, COVID-19 doesn't play fair. It hasn't. It's a terrible condition. The pandemic of unprecedented and with different variants, like shifting the goalposts. So it's not easy, but we, as part of healthcare, we cannot just relax and just throw our toys out the court. We respect the activism to make sure that our colleagues who are in the front line, in the trenches, in the dust, are supported,
Dr.
appreciated,
Kgongwana,
and
unfortunately,
yes.
we're going to have to leave it there for tonight. He's the acting DDG of Hospital Services at the Gauteng Department of Health. I wish we had more time, but we're just going to simply have to leave it there for now.